Good morning to everyone. I'm Fabio Gorni, and today we will talk about non-surgical retreatment. Non-surgical retreatment is a huge topic, but today we want to underline the cases where we should use mineral trioxide aggregate. That's why we will show cases about perforation and large foramen where the mineral trioxide aggregate is one of the most important part of the treatment. As I already told you, non-surgical retreatment include a lot of problems, in particular iatrogenic problems, like in this case where the colleagues did an incredible access cavities and he did a lot of mistakes, a wrong path on the mesial aspect of the roots, a perforation in the distal part of the cavity, a broken instrument in the palatal roots, and a missed canal in the buccal aspect of the tooth. So one of the problems that we have to face every day, especially today, where the nickel titanium is one of the most used instruments in our work, is the retrieval of broken instruments. And we know that to resolve this kind of problems, we need a microscopy. And most of the time, when we want to try to remove instruments inside of the roots, we can do another big mistakes, perforations. So be careful. When happens, try to understand exactly if it's possible to realize our project and remove the broken instrument, or we have to face in another way the cases. This is the typical case that I want to show you, and this is what can happen if we want to try to remove a broken instrument without any expertise and any equipment. This is a typical case that I told you before. A broken instrument in the apical 1/3 and a perforation in the middle 1/3 of the roots, because the colleague tried to remove the instruments without any special equipment, and in this moment now we have to solve two problems. We have to remove the broken instrument and to repair the perforations. Of course, when happens, our problems are more than one, and the difficulties of the cases increase a lot. This is the post-op after the treatment and the follow-up after 13 years. Thanks to the MTA today we can solve a lot of problems, and one of the biggest problems are perforations. When we are talking about perforation, we have to understand exactly some point. First, the position of the perforation, the tooth type, if we are talking about the single rooted teeth or multiple rooted teeth, and the extension of the defect. All this part must be understood exactly before our interventions. In the past, we try to repair a huge perforation, but today, and then I show you a research about the follow-up of the perforations. Today, we understand that the dimension of the perforation is one of the most important part of the problems. The location of the perforation as well, because of course when the perforation is located on the pulpal floor, our action is simpler, and most of the time we don't need any particular magnification to face it, like in this case where the access cavities was done improperly, and you can see clearly on the slides how is important the access cavity, how is important to clean everything, and then I show you the technique about this kind of activity. So position and extension of the perforation are really important aspect if you want to face correctly the problems. In this case, for example, we can see two different situations. In the molar, we have two different problems. One perforation is located on the pulpal floor, the other one in the middle 1/3, plus a lesion of endodontic origin. The follow-up shows a perfect healing of both problems, but the difficulties to reach the middle 1/3, like in the bicuspid, in the lower arch, is completely different. And can you imagine that the devices that we can use to reach the perforation, to clean the perforation and to repair it is really important. Recently, our group published a clinical research about the follow-up on the perforations, and the success rate was really great, more than 90%. And if you follow the healing of the lower premolar, you can see all the history of this case and the incredible situation after 16 years. As I told you before, not only the extension of the perforation is very important, but also the shape of the perforation. Usually when we are talking about pulpal floor perforation, we are talking about handholds inside of the pulpal chamber. But when the perforation is located in the roots, sometimes we have to face stripping. So we don't have enough thickness of the dentinal wall for our materials. So all the procedures are more difficult. So that's why when we want to talk about thickness of dentinal wall, we have to include also the length and the depth of the perforations, because it's completely different when we have a tunnel. Most of the time, this kind of problem has been created for the preparation of the dowel space. So with the birds, that's why we have a tunnel. And when the tunnel is greater than 1 millimeter, we have a favorable situation because we have space for our material. So we can push the material inside of the tunnel and have enough space to create a greater sealing. In this case, we can see two different cases, the lateral incisor and the lower molar, but the defect is very similar. And in cases like this, our action is not so difficult if we can clean, shape, and pack correctly the perforations. When we don't have any tunnel and the lesion is located in the middle 1/3, especially when we are talking about a stripping, we have to face the problem with another technique. I described for the first time the sandwich technique in 2003, and now I want to show you the case that was the first case that I treated with this kind of technique. These cases were referred to me by the colleagues because the tooth had some problems, and the patient, after a surgery of the wisdom tooth, started to have problems on and pain on this tooth. The colleague tried to treat the lower molar, but in the distal root he got some problems. So that's why he finished the therapy in this way. I remove all the material in the distal root, but in the intra-op X-ray is clearly we can see clearly the lesion done by the burrs during the surgery that's created a problem from the external surface of the root in this molar. So that's why we decided to treat it, the apical 1/3 with the normal technique, so cleaning, shaping, and packing with the worm gutta percha, and then pack the middle 1/3, all the middle 1/3 with the MTA in a sandwich. So in the apical 1/3 we have worm gutta percha, in the middle 1/3 MTA, and above the MTA we can put gutta percha, or like in this case, composite and post. So that's why the name sandwich technique. Now we can see the follow-up after 12 years. When the therapy has been done correctly, we can use the sandwich technique also in a simpler way, because in this case it's enough to remove the gutta percha in the middle 1/3 and substitute the gutta percha with the MTA. So that's why in cases like this, the therapy is really, really simple. In the video we can see and we can follow all the procedure in the lower molar, where we have a perforation or a stripping in the middle 1/3, and now after cleaning and shaping we are packing the apical 1/3. To follow in the correct way the technique, we need to control perfectly the exudation from the perforation, but through the microscope we can do it. So that's why we can pack the apical 1/3 of the root without any problem. After the packing, we can clean exactly the other part of the canal, and we can use a microbrush with sodium hypochlorite or with alcohol just to prepare the area for the MTA. It's a simple procedure. Then we can dry a little bit the area, and with the map system we can push the MTA inside of the roots. It's really, really simple to do it, because we don't have any problem to control the MTA, and we can pack the middle 1/3 easily using a plugger the material. In this case we are using a gray MTA. We are talking about a very, very old case, more than 15 years ago, but the technique is even the same. With the map system or with the map 1, we can bring easily the material inside of the canal and control everything. Here another case, more recent, where we can show also the first part of the treatment. The first part of the treatment is really, really important, because we have to clean everything, and through a correct access cavity we have to understand exactly where is located the problem. Using ultrasonic tips we can change a little bit the shape of the access. We can clean the area between the mesial orifices, and now the situation is more clear. We can see above the orifice a perforation in the focal area. So that's why now we have to remove, if we want to treat the system before the reparations of the perforation, we have to make two different actions. First, we have to remove all the gutta percha from the canals and then clean, shape, and pack the root canal system. And after that, we will repair the perforation. So that's why we are talking about sandwich technique. Also in this case, the control of the exudation is perfect. Of course, using the microscopy, we can control much better that area. So that's why is absolutely indicated the use of microscopy. With the paper point, sometimes we can dry the area. So we are talking about a large perforation in the focal area. In this case, we are talking about a perforation located more than 3-4 millimeters under the pulpal floor. Seeing the video from the microscopy, the perforation look like very shallow, but is not true. So that's why it's not so easy to control all the phases of the treatment without any magnification. To have a better control of our area, I use a matrix, a collagen matrix, beyond the perforation, and then I will show you everything about the collagen matrix. Now the therapy is finished, and we will very easy to push the MTA in the space to close everything in a sandwich technique. Which is the limit? We already talked about it. The limit is the dimension of the lesion. In the past, we did and we try to repair a huge perforations, but with a lot of failures. So that's why the extension of the defect is one of the most important aspects that we have to understand. 100% of the failures in our research are located in multi-rooted teeth and when we had a pre-op probing. So that's why this is another important aspect that we have to realize, because when we have to face perforation located in molars and we have a pre-op probing, a deep pre-op probing, so we don't have integrity of the periodontal ligament. So that's why when we don't have any integrity of the periodontal ligament, our success rate decreases a lot, especially when the probing is greater than 5 millimeters and the size of the lesion more than 3 millimeters. Now I want to show you step by step the technique. That is really important, because we have to follow specific steps if you want to reach the success. This is one of the first cases that I treated more than 19 years ago, and was a big problems in upper first molar with a multiple perforation, and the final result 15 years later is a great result. But now I want to show you step by step the procedures. First, we have to clean and shape exactly the area of the perforation. In this case, the previous treatment packed the perforation with the gutta percha cone. So they did a big mistake. They thought that the perforation was the canal orifices. So that's why they use the gutta percha cone inside the periodontum. So if we want to reach a great success, we have to remove the material inside of the perforation. After that, we have to clean the dentinal wall of the perforation, and we have to understand if the thickness of the defect is enough to maintain our material. In this case, we have two different situations. The palatal perforation is correct in shape, but the other one is not. So that's why we have to change the shape of the perforation. We have to make the perforation a little bit bigger, but we need a thickness of the dentinal wall that can receive the material, and this is one of the most important aspects of the technique. So first, you can see the changing in the shape of the perforation, and in the video we will follow much better the step. With the probe, I'm showing you the original size of the perforation, and using an ultrasonic tips, I can change a little bit the shape of the perforation. I can clean the dentinal wall, especially when the perforation is an old perforation. We have to remove bacteria inside of the dentinal area. So that's why it's really important, these actions. It's a gentle actions done with a small power, but we can follow the original shape and enlarge it a little bit. Then, of course, we will use sodium hypochlorite to decontaminate the area. And the bubbles that we can see on the pulpal floor are showing us the action of the decontamination. So now we are ready for the packing. When is it not possible to control the bleeding and the exudations, we can do a double visit. So in the first visit, we can remove all the material inside the perforation, clean and change the shape of the perforation. Then we can do a medication with the sodium hydroxide, calcium hydroxide, and done another appointment, and in another appointment we can finish the treatment. Usually when it's possible to control everything, I do this kind of treatment in a single visit, but when it's not possible, the best material that we can use for the medication is the calcium hydroxide. And after the medication, we can see how is different the situation inside the perforation, and everything is under control. One of the other very important steps of the procedures is the packing. But before the packing, we have to be sure that we can control the position of our material. So that's why sometimes when the defect below the perforation is a big defect and we don't have any tissue that can control the position of our material, we can use an extra collagen barrier that can do a matrix below our perforation and help us to control the material. When we want to use the extra root barrier, we have to understand that the barrier must not occupy the endodontic space. This is really important. So that's why we have to check the depth of the defect, and then, and only after then, push the extra barrier outside of the root. Now we can see the difference. No barrier, no control, so the material has been pushed outside of the root, and with the barrier, where the control is optimal and the material is completely flat and inside of the anatomy. A video shows the procedure. In this case, we are using fibrin. That is a cheap and nice material to use it. Sometimes we have to push outside of the root a lot of materials, especially when we are talking about an old lesion, like in this case. So the defect outside of the root is a big defect, and we have to push material outside until we can obtain a nice surface. Over that we can then pack our material. Don't worry about to push material outside. Is completely resorbable material, and in this case is much more important to control the MTA later. With the collagen barrier, we can control also the exudation, especially when we have an active exudation. So remember that the MTA, we can use MTA with moisture, in humidity, but don't forget that the humidity is perfect for the MTA, but we can't have active exudation. Otherwise, our material will be dislocated from the area. We need more barrier. In this case, we are talking about a really huge defect outside of the root. And this is the final result. As you can see, the material is completely inside of the root, and the shape of the material is completely flat. The reason is a perfect barrier outside of the root. Now we can talk about the adaptation of the materials. MTA is a soft material, so we don't need to push it with a strong action inside of the defect. So that's why most of the time I'm using a paper point, the back of the paper point, to adapt the material inside the perforations. Don't push too much, also because the extra barrier is a soft barrier, so that's why we don't want to push material outside of the root. So it's an adaptation, it's not the packing. In the video we can follow the different steps of the packing, and with the MTA endodontic gum, I'm bringing the MTA inside of the perforation and gently adapt the material inside of the perforation with the paper point. We can change a little bit the consistency of the MTA using the paper point, because if the MTA is too soft, we can use a dry paper point. If the MTA is too dry, we can use a wet paper point. As you can see, we are using a gently action. Don't push too much. In the second perforation, we will use the MTA a little bit softer. First, we are checking the situation about the tissue beyond the perforation. In this case, we didn't use any extra barrier because the tissues was enough to contain the materials. In this case, the perforation is a little bit smaller, so that's why I prefer to use the MTA a little bit soft. The action is even the same, and with the paper point, in this case a dry paper point, we are adapting the material inside of the defect. With a couple of actions, we will finish our packing also in the second perforation. For sure, it's not a difficult procedure, especially when the perforations are located on the pulpal floor. After 2 or 3 days, we will check the consistency of the MTA, and if the setting is completed, we can finish the treatment. This is the post-op, and this is the last control after 19 years. The other pathology that has been changed completely with the use of MTA is large foramen. Many years ago, when we treated large foramen, we were in trouble because the packing of that area was really difficult. But today, with the new materials, we changed completely our approach, and so we skipped the surgery, and large foramen has been treated directly with a non-surgical retreatment. The technique is even the same. We already described the technique for the perforation, but the technique is even the same. We have to clean, shape, and pack the area, change the area where we are working. So now we have to work in the apical 1/3 of the roots. But as you can see, the success rate is very high. Here a couple of examples, that's large foramens, and as you can follow, the post-op show a perfect healing also in a huge lesion, like in the central incision on your left. At the healing after 13 years is incredible. Same in case of trauma in a young patient in the right case. Like in the case in your right, after 7 years. In the video, we can see the disassembling of the tooth. This phase is the most important step of the treatment. We are removing with the ultrasonic tips the cements inside of the root, and after that we have to remove all the endodontic materials. When the canal is very large, remove all the material is one of the most difficult steps of the procedures. It looks like simple, but it's not true. And when it's possible, we have to try to remove the material without any solvent, because otherwise it will be really difficult to remove all the gutta percha inside the canals. Now I'm trying to remove the gutta percha using the ultrasonic tips. The the vibration of the tips help us to remove a little bit of the gutta-percha. But trust me, don't heat the gutta-percha too much, because otherwise it became too soft and will be very, very difficult to remove it. In this case, after the first actions, I'm using a K file, an angstrom file with an handle, and try to catch the gutta-percha cone inside of the canals. And as you can see, it's not too easy to do it. It's not easy to do it. And try to pull it outside of the root, but need time. If we can't remove completely the material inside of the canal, we can't put MTA in the apex. This is really, really important. Okay, now we are starting to remove the materials. Some different gutta-percha cone inside of the canals, and so we can combine the actions, manual files to grasp the canal, to grasp the gutta-percha cone and remove it, plus ultrasonic tips and activation of the irrigants inside of the canals. Of course, we have to be sure to don't push irrigants outside of the roots. In this case, we must be shorter to the apex, because the apex is very, very large. But we have to use the combination and improve the cleaning with the activation of the irrigants. A gentle irrigations with the needles, and then we can check inside the canal if the canal is completely empty. It's not, so that's why we have to use again the instrument and try to catch the last gutta-percha cone. In this case, I change the ultrasonic tips, and I'm using a K file, an ultrasonic K files, so I can move my action deeper inside of the canal. Okay, the last gutta-percha cone has been removed. And now we are ready for the packing. Also in the large foramen, the use of the matrix is one of the most important steps of the treatment. It's really important that the material that we will use must be resorbable, with a good handling, and if it's possible, inexpensive. In the left case, we can see the after of the barrier that is completely changed on the case on your right, where we didn't use the barrier. We can push the barrier outside of the root with a plier. It's not a difficult action, but also in this case, we must control that the barriers stay outside of the root and not inside, because inside we need the space for the MTA. We can follow the step of the procedure in the video. I'm using the collagen barrier, and I'm pushing the collagen barrier with the plier. If we are using microscopy, we can follow the steps easily. If we are not using microscopy, we can check the depth of the material through the working length. The action is a simple action, and more the foramen is large and easier is to push the material outside of the root. Now the barrier is positioned, that's now we can try to use the material. Now we are ready to pack the apical 1/3 and do the apical plug. The best devices that we can use to bring the material inside of the apical 1/3 is the map system. So the MTA and the gun, we need it. We can't do a very good job without the gun. So it's one of the most important devices that's we have to use it in this technique. Also, for the apical plug, we can use paper point or use also the plugger. If you want to use plugger, please use gently the plugger. As I remember, you before, we don't need to push too much the material because material is soft, so we only gently adapt the material inside of the area. Today, we can use another different kind of MTA, the white MTA. That is different in terms of composition. The last MTA was with the bismuth, and the bismuth created a big problem in the past about discolorations. So the new formulations without the bismuth prevents discolored effect. And this is really, really important when we have to repair perforation in the frontal area, where the static problems is one of the most important problems that we have to solve in the patients. When the apical plug has been done, we can put a wet pepper point inside of the canals and just wait a couple of days to finish the treatment. After 24 or 48 hours, we can check the setting of the MTA, and if the MTA is completely hard, we can finish the treatment and put some gutta percha inside the canal and then restore the tooth. The follow-up shows us a perfect healing also when we are trying to resolve problems in large foramens. We started to use MTA close to 20 years ago, and we're still using this kind of beautiful material in many, many cases, and is one of the most interesting material that we can use in endo, especially for perforation and large foramen, and in surgery as well. Maybe next time we will talk about surgery. Have a nice day.